Hey guys, and welcome to the Beyond Physio podcast, the show that brings you to the next level. So, I'm Dr. Alex.
I'm Dr. Nick.
And today's podcast, we're coming to you to talk to you a little bit about knee pain. This is a very common injury. Actually, about 25% of the population lives with chronic knee pain. And so it's very common. We see it in our practice all the time. And oftentimes what I hear, and Dr. Nick, you can attest to this, that we have patients coming in and they'll say they'll visit their healthcare practitioner, their primary care physician, or a doctor, and say that they have knee pain, and basically what they're told is that they have chronic knee pain due to age. This is typical of your age, or wear and tear, or the sport that you are participating in is causing the knee pain or the wear and tear. And so there's not much to do about it except maybe an injection, total knee arthroscopy, meniscus surgery, etc. But without getting really to the root cause of why it happens and what exactly is going on in the knee joint. You just know you have knee pain and you'll do anything to kind of take care of it and get back to the sports you love. So I think it's really important to start this whole podcast off to just talk about what the knee joint is, because most patients, I think most people, really think of the knee joint as a hinge joint, or if you think of a door hinge where it kind of swings one way and swings back, and that's it. But it's a little more complicated than that, right?
Yeah. It's a little more complicated than that. So the knee joint, to me, is this joint that it kind of takes the brunt of the load between the hip and the ankle. So whenever our patients go see the doctor and then they're just told, like, yeah, your knee has some issues in there, they'll spout off a bunch of anatomical things that don't mean much to the patient, but very few times does it get related back to their function. So to me, the knee joint, it has a relationship. You may have heard of the femur and the tibia. So it sits there with the patella on top of it. For our patients, they'll come in with prescriptions that say they have, meniscus tear or, ligament sprained. But really for us, what we look at on the knee is just like, how well is everything above and below it moving, as well as the joint itself. So for me, whenever I, get a knee, you said that it's a hinge joint, and I absolutely agree. And as you alluded to, there's a lot more that goes on there. So there's a degree of just like rotation that happens within your knee that a lot of, not just, the whole medical system kind of misses that sometimes. We have this very fun term called the screw home mechanism. It's where we lock our knee out when we're walking.
And I think that's important to talk about, that screw home mechanism. So that mechanism that we talk about, it's what gives us the ability to wait online for the new Apple iPhone to come out and to get it without losing strength in our legs. And we can stand online for an iPhone or for a new movie or basically at Disney World, and without getting too tired in our legs. Once we've lost that, where we don't have that screw home mechanism where the knees actually kind of lock into place, we don't have what we talk about an axial load, but basically a balance of your weight balance over your bones or stacking appropriately. And so what happens is your quadriceps or your muscles take on more of the load than they need to, and they get very fatigued very easy. And as you were talking about, there's that rotation. We have the patella and your femur and your tibia, and these are all, your femur is your upper bone in your leg, your upper thigh bone, and then there's the tibia, as well as the proximal or the closer tibiofibular joint, which is right around your knee, which is often overlooked and can add to that pain that we were talking about.
Absolutely. And, I think that for our viewers, they care a lot about, what's going on in the knee. But the best way I found to help patients is to kind of just help them understand, like, functionally, what do we need to do today when you walk in and get on my table? What's going on in this knee that needs to get a little bit better? And for a lot of my patients, they'll come in, we'll talk about, yes, your knee hurts, but we got to look above and below as well. So for a lot of my patients, the very first day, like we talked about that quadricep, we just talk about, this muscle in the front of our thigh. How do we get that thing to fire better to allow your knee to kind of like bend all the way and extend all the way?
Mhm.
And I think you and I both spend a lot of our day with our patients who have knee issues talking about the importance of the extension of the knee joint. But do you want to tell the viewers a little more about what that is and why it's so important?
Oh, sure. I mean, hey, sure. We know that um, through research, we've found out that a normal range of motion is anywhere from 2 degrees to -2 degrees on either side of that knee joint. So what that really means is that if you are 2 degrees off from straight, completely straight, or even below -2 into a hyperextension, or basically your knee traveling the other way, that is what we consider normal, or normal stacking, and that's dependent on everyone's anatomy. However, once we scale out of that, if you're 3 to above degrees of missing extension, or below that or past that, that can lead into some really serious trouble, right?
Yeah, no, absolutely. I think for a lot of the patients, they want to know why these things are missing. And after like a certain amount of trauma over the years, like enough impact on the joint when you're missing like certain amount of flexion or extension, we know extension is super important. Extension is, when you take a step forward, you want your knee to straighten out all the way. You can't really walk without a lot of that. Like it doesn't happen normally. How that comes to happen is through, we talk about just bad positioning of the joints. Sometimes your hip's not aligned or your ankle doesn't have all the motion inside of it. So we need to restore all those to restore as much motion as possible. I think having the best fighting chance in any patient is to just, renormalize as much range of motion as possible. If somebody is missing a lot of knee bend, we don't tend to, it's important to get that back, for all of our yogis out there when they want to do their child's pose, or they want to, hit some of these certain, positions, they need to have that. But for every human being, you need as much knee extension as, well, not as much as possible, but you need at least extension to 0. That just, if you are a patient with knee pain on my schedule, if we don't get that thing as close to 0 as possible, we are getting a suboptimal outcome. So I think that's pretty important.
Yeah, and some of the research has shown that if you're outside those 2 degrees of off from normal, it leads to more osteoarthritis in the future and greater strain on some of those ligaments. So we talked about the knee complex as being all these bones, and there's shifting and rotation and hinging. So it's a lot more complicated than people think. But then also, we have a ton of muscles that connect right around there. Our knee is actually a pulley system with that patella, and most people don't know that kneecap. And you have muscles connecting to the left, to the right, behind, in front, all of which can add to this knee pain that may not necessarily be coming from the joint itself, but rather a strain or a malalignment, I guess, of your knee as you are either participating in the sport or just sitting down or walking.
Yeah. I something like, if you're listening to your car, like when you get to wherever you need to go, just start looking at people's knees. It's about to be winter, so it's going to be cold outside, but there's a lot of people where you look at their shin bone, like you can just see it's just turned out a little bit. So we talked about that screw home mechanism earlier. There's a lot of people who are stuck in that screw home mechanism for complicated reasons. But I have found a lot of success with just getting that bone to turn in a little bit, especially when it comes to restoring like a full knee bend. Like if we can get this bone and just rotate it in a little bit, that's where that rotary component comes in. And it just helps. Like that's where I think we can get our bend and we can get our extend back. But if we don't get this twist of the knee back normal, I think that we are doing a disservice for a lot of our people. Just because most physical therapy, we're going to start out with some pretty basic exercises. But when we start talking about doing activities where there's cutting, lateral movements, plants, and like twists, we need to make sure that we've gotten back as much normal range of motion as possible.
Yeah. So is it safe to say that when these patients hear, oh, it's due to your like wear and tear and maybe the sport that you're playing, would it be safe to say that maybe not necessarily due to the sport, or yes, there's wear and tear, but why is there wear and tear? Like maybe this screw home mechanism or this rotary component in the knee is just not working optimally.
Yeah. I think the question is for a lot of our patients, what were you doing before this? Like in your life, like what does your overall systemic global posture look like? Because that's a tough question. When we say that we want to get to root causes for patients, like if you come in with a prescription for your knee, if I'm just looking at the knee, I'm doing wrong by you. And then that's the question of how much investment can I get from my patient into the process? Because there's some people who want to come in and they're like, hey, it's just my knee, just work on my knee. Or how well am I doing my job to help you understand that this goes past the knee? How have we set you up for success with your activities? And I guess that's the idea of sometimes we need to regress this process when people come in for physical therapy. They're like, I want to get back to sport as soon as possible. And that's where we kind of have to tell them like, hey, we need to set up a solid foundation first. And that solid foundation is the overall systemic posture that they are, coming in with. So if you come in and you have like this big curve through your lower back, and then, you have no knee extension, sometimes I know I need to go look at those hips and try to figure out, can we get these hips to shift their position to allow your knee to show a better posture? So yes, the wear and tear from your sport matters, but I also think that, were you giving yourself a fighting chance in the first place? Were you optimally aligned in the first place? In sport, we're not always going to keep a perfect alignment, but I think that in the recovery times from your sports, you need to be able to find a more neutral alignment so that your joints have a better ability to recover, and you're not going into your next session or your next, event with a bunch of malaligned joints to, that where a knee is going to end up taking a pounding.
Yeah. We said it before. The knee is that joint in between the hips and the ankle, and it takes on all that blunt force or that force that the hips or the ankles possibly are distributing up towards the knee, because something's going on with the ankle. So this brings up a good point. So now you said you look at the joint above and below, and then just the normal kinematics of anyone either walking, running, performing that sport that they love to do. So what are some things that you see in possibly someone's ankle that may lead to knee pain? So people are coming in, I have knee pain, and it seems like, okay, your knee actually functions pretty well. So what else is going on there?
Yeah, so especially for my people who have had chronic ankle sprains over their lives, or ankle fusion, or just a bunch of trauma in the ankle in general, they are missing something called dorsiflexion. So if you listening at home, dorsiflexion is basically just your ability to pull your toes up to your nose, right? If you do that while you're just sitting here right now, that's dorsiflexion. Sometimes that motion gets really jammed up in people for one reason or another. Ankle sprains are a big one, and they just never get it back. So I know we're talking knees, but I think that like with ankles, when you sprain them, if you get put in like some sort of a boot or immobilization for too long, it can cause that issue where you just don't get that motion. Now, every time you take a step, your step gets cut short. So your ankle just can't demonstrate this full range of motion while you take a step, and then your knee takes the brunt of it next. Sometimes it skips the knee, goes right up to the hip. It depends on a lot of factors based on how you're built, but that's mostly what I see within the ankle. It's usually jammed up, for lack of a better term.
Mm-hmm. Yeah. And so possibly increasing the range of motion and the fluidity in the ankle itself may help the knee up the chain.
Absolutely. We worked together long enough where you see me pull on like ankles for people with like neck pain, and it makes a difference. So like it really starts with like this gait cycle, or like basically your ability to walk. If that's not normalized, starting from the ankle, the knee is definitely going to take a beating, whether it's today or it's 10 years from now. You don't want, as best as you can for the rest of your life, you want to take as many normal steps as possible, right? If that's missing, you're kind of screwing yourself for the future.
Yeah.
That makes sense.
So we've talked about increasing that mobility and that range of motion, not only in your knee and making sure that works optimally, but also in your ankle joint and your hip joint and every other joint, really, because your knee is just an access point where these ground reaction forces, or basically just forces from your body, are going to eventually come to a point and create that friction or that tension in that knee. But another thing that we were talking about is strength and weaknesses, or the opposite side of the coin on that one, in and around the knee. So what would you say in terms of someone is coming in with good range of motion, but they have weakness, or you've been working on their range of motion, and all of a sudden they want to go out and they want to, go back to squatting 300 pounds or something like that?
Yeah, no, absolutely. I think that like one of the biggest things, if you've ever had a knee injury, we definitely need to make sure that the strength between both legs is renormalized and reoptimized. A lot of times with physical therapy, we'll send our patient, we'll discharge them before they actually get the full strength back in their leg. And the reason being is that takes a long time. One thing we'll do on almost everybody that walks in is we'll measure their legs. And like sometimes you'll see like a 5 centimeter difference between both legs. And it's, not because of swelling, it's because the muscles just aren't as big. If your knee has had any period of time in your life where it didn't want to bend the right way, the muscles are going to do something called atrophy. They're going to get a little bit smaller. They're going to get a little bit weaker. So now you renormalize your knee motion, and then we send you out to go play sports before we get that strength back. Sure, you're going to have the range of motion, but you won't have the protective factors in your knee to stop it from just buckling on itself, or stop it from when you run or when you jump and stop, you need to take up a lot of your own body weight. It's amplified.
Yeah. And this might actually be happening for people who don't even know it, right? If you are possibly favoring one leg during a sport, or you are always turning one way in a sport, it's very possible that one leg is slightly atrophied, or there's a muscular asymmetry or an imbalance between those two legs. And that obviously can cause some serious repercussions, as you've kind of alluded to.
Absolutely. I think so far, I don't think I've ever done wrong by somebody by delaying them to let them get that strength and that muscle size back before I return them to sport. Sometimes when the patient jumps the gun or I jump the gun, that's when we see those little twinges come back, and then we have to nip those in the bud before they become something even more serious. So just having an ability to quantify the strength between both legs is super important. We'll do that through just testing, hey, can you jump off of this one leg the same as the other leg? So we'll do a single leg jump, and we'll get a measurement of what's going on between the two legs. And that's an easy way for us to see hey, do you not only have the muscle there to do it, do you have the ability in your brain to recruit these muscles to, demonstrate the same amount of power or explosiveness or just overall strength. It's really important for patients to protect them from future injury.
Yeah. I think everyone has a more dominant leg or a more powerful leg. I think I heard you in the clinic talking about you're a goofy skateboard.
Oh, yeah.
I ride goofy too. Yeah.
Yeah.
Anytime snowboard or my left leg is the stance leg, and, or my right leg is the stance leg, and then the left leg's the kicker. So yeah, everyone's got a different preference on their leg. So one, typically is a little more dominant than the other. But when you see stark weaknesses between the two, then it leads into some trouble.
No, it's funny you say that. I think consistently on every patient I've ever treated, there is a leg they are more able to stand on, and there's a leg they're more able to propel off of. And when those two things, that little difference becomes super amplified and that magnitude becomes too big, that's when bad stuff starts to happen. And not even just in knees, that's where we can get back pain from. All sorts of bad things happen when you just lose that ability to do it on both sides. So that's, definitely a good point. And I totally am a goofy wakeboarder and skateboarder.
Yeah.
So I paid for that with my own injuries in the past as well.
So let's talk about the other side of the coin on this one. So we talked about someone who's too weak, and now they're trying to get back into the sport, and we have to progress them conscientiously. Now let's take the person who might have overdevelopment of, let's say, muscle tone. So I don't want to call it strength, because strength doesn't always mean immobility. But let's say someone's coming in with a almost hypertonic muscle, and so it won't allow those joints to flow freely as much. So muscle tightness, more or less.
Yeah, no, I think that, when you look at knees and you're just like, wow, this entire thing around here is so tight, but it's tight and it's not strong. That's to me something neurological in your brain that just, you want it to be stable, and now we've just lost that idea, and now it's just useless protective tone that is now just becoming something that we need to work super hard at loosening up for the patient. So like I'll see that a lot on the outside of somebody's calf, a lot when they have had knee pain for a long time. To me, that's just a joint that's looking for stability that's now turned into just useless protective tension around the joint that we now need to loosen up and then re-educate on how to feel or how to be recruited in a more productive way. So whenever you feel like muscle's tight around, we know that like sometimes the patient will go, well, it's so tight, why isn't it strong? It's a whole conversation we have to have about it. Yeah, it's tight, but it's not strong. So we need to loosen it up and then teach it how to be strong.
Sure. Yeah. And we have so many patients who maybe come in for knee pain, but we have tests like the Thomas test that tests basically your hip flexors, Epley's test for quadricep lengthening. There's something called passive insufficiency. And I know that's a big term, but basically the long and short of it, it means that your muscle is so tight or restricted that your joint actually won't move through its normal full range of motion, because the muscle is actually the inhibiting factor and not the capsule in your knee or the meniscus or anything that's getting stuck in it. So these are, we've talked about being too weak to control your knee. Now we're talking about hypertonic muscles or muscle, inhibition so that you can't move your knee because of too much tightness. We've talked about lack of range of motion in your knee and your ankle and your hip that can lead to knee issues, but also back issues, shoulder issues, all the way up the chain because of that closed kinetic chain. Or basically, if one of your joints moves and you are standing on it, it's going to affect every other joint that's coming up the line. Are there other things that you have heard that are pretty typical in terms of like knee pain?
Yeah, heard or like even seen, just like with what we do, we sometimes get patients who have not succeeded in other physical therapy clinics. And I think that there are some easy wins out there for knees that we should probably, be looking on for everybody. So I think that like when there's residual swelling, so like we typically associate swelling like, hey, I just twisted my knee, now it's swollen. I don't think we talk enough about the swelling that gets left behind in chronic, pain or chronic pain, chronic injuries. Like it's been going on for months, but like this knee is chronically just a little more puffy than my other one. For those people, I think their best, marker of success is it's not ice, compression, elevation all the time. Those things help, but the swelling's still there and they probably tried that stuff. How well did we get them, or how good did we get them at contracting the muscles in the knee, especially the quadricep? I have found a lot of success getting swelling out of knees by teaching people how to use that quadricep. So we talked about like active and passive insufficiency just now. A lot of people will like try to do a long arc quad. And for viewers at home, that's basically just sit in your chair and then straighten your leg out. And it doesn't work as well as the other side. I've found success just laying people on their backs and just, putting a little towel underneath their knee and just getting them to kick it straight. That just gives the quadricep, that muscle in the front of your knee, just a better orientation or a length to just fire a little bit better. And when we get that working, I find that we get the fluid just to come out a little bit easier. And that's just an easy win for all knees. That I've had success with in the past.
Yeah, absolutely. I mean, in our clinic, we have Normatec compression boots, we got voodoo floss bands, and et cetera, et cetera. But when it comes right down to it, the best way and the easiest way to kind of get fluid out and moving all that synovial tissue to go is contracting that muscle.
Absolutely.
Movement is the way it goes.
Yeah, no, 100%.
Yeah. Dr. Nick, thank you so much for being on the podcast and talking about knees.
Thanks for having me, man. I appreciate it.
And thank you guys so much for tuning in, and make sure you like, subscribe if you want to see more. Make sure to check out next week's episode for more tips and tricks from us physical therapists on how to reach your next level.